obesity. So we are going to talk about obesity based on American College of Cardiology guidelines and diabetes care guidelines, which was published a few months ago. Obesity is a debilitating chronic disease with cardiovascular implications, including increased risk of heart failure, coronary artery disease, and stroke. Obesity is affecting more than 1 billion adults worldwide. Across 3 decades, obesity rates in adults have doubled, and in children and adolescents, they have quadrupled internationally. In the United States, 40% of adults have obesity, meaning BMI more than 30. 9.4% have severe obesity, meaning BMI more than 40. Severe obesity is associated with significant reduction in life expectancy, about 9.1 years in men and 7.7 years in women. So the treatment is critical. In general, the weight loss threshold for risk reduction are 10 to 15% for cardiovascular disease and more than 50% weight loss for cardiovascular mortality. And also, it protects the patient from heart failure with preserved ejection fraction, while the treatment of obesity preserves. The weight loss achieved with lifestyle intervention has not been associated with a reduction in adverse cardiovascular outcomes. Very important point. Many people think lifestyle modification along with exercise can reduce the weight, but it has not shown to decrease the adverse cardiovascular outcomes. On the other hand, bariatric surgery can produce weight loss and also it reduces cardiovascular events. The modern obesity medications can cause weight loss as well as reduced cardiovascular events. Overweight and obesity are defined as abnormal or excessive fat accumulation that presents a risk to health. At a population level, BMI is a useful measure to assess excess weight, but among individuals, it varies. BMI may be higher because of the muscle bulk, not necessarily increased fat tissue. So each and every individual needs to be assessed differently or individually. And also, one need to use other anthropometric measures like waist circumference, waist and height ratio, so on and so forth. So classification also inaccurate across the racial groups. For example, in South Asians, obesity means more than 23, Chinese more than 25, in Caucasians more than 30. These are all the obesity threshold in different racial groups based on JACC 2025. The healthy weight is 18.5 to 25. Overweight 25 to 30 in Caucasian, in Asian 23 to 25. Obesity more than 30 in Europeans, in Asians more than 25, even among Asians, Indians more than 23, Chinese more than 25. Class 1 obesity is 30 to 35 in Caucasians, class 2 35 to 40. Class 3 is more than 40. There is no classification for Asians and Indians. One can use waist circumference and also waist to height ratio. The etiology of obesity is multifactorial. It runs in the family. There are some neurologic and psychological reasons for the obesity, and nutrient and hormonal imbalances, environment, and social factors, social determinants of health, and medical conditions that can cause obesity too, like hypothyroidism, Cushing disease. It results in type 2 diabetes, insulin resistance, hypertension, dyslipidemia, sleep apnea. A little bit dissect further into excessive adiposity, which is obesity, affects five different areas. It causes increased adipokine synthesis, increased lipid peroxide production, increased activation of sympathetic nervous system, and increased activity of renin, angiotensin, aldosterone system, and it poses mechanical stress. This increased adipokine synthesis, increased lipid production, increased activity of sympathetic nervous system, increased activity of renin, angiotensin, aldosterone system will result in impaired insulin resistance, release of fatty acids causes lipotoxicity and dyslipidemia, and activation of sympathetic nervous system can cause hypertension, and the activity of renin-angiotensin system again causes hypertension. In addition, the fat deposition around kidney can cause hypertension too. It results in type 2 diabetes, insulin resistance, non-alcoholic fatty liver disease, steatohepatitis, cirrhosis, coronary artery disease, and resulting in congestive heart failure, stroke, and chronic kidney disease. The mechanical stress because of excessive fat can compress around kidney, pharyngeal soft tissue, mechanical load on joints, and intra-abdominal pressure. It results in obstructive sleep apnea, osteoarthritis, gastroesophageal reflux, Barrett's esophagus, and esophageal adenocarcinoma. In addition, excessive obesity, especially in visceral adipose area, can cause or directly linked to colorectal cancer. Obesity is associated with following heart conditions: atherosclerotic coronary vascular disease, heart failure, most commonly heart failure with preserved ejection fraction, atrial fibrillation, sudden cardiac death, venous thromboembolism, and pulmonary embolism, and valvular heart disease. This is depicted in this picture. Obesity can cause valvular heart disease, venous thromboembolism, atherosclerotic heart disease, heart failure with preserved ejection fraction and reduced ejection fraction, atrial fibrillation, and sudden cardiac death. When you treat the obesity, it causes weight reduction, reduces cardiovascular risk factors, and it reduces the mass, which is major adverse cardiovascular events, heart failure and hospitalization, reduces steatotic liver disease, and also CKD progression. These guidelines focus on NSH, nutrient-stimulated hormone. The nutrient-stimulated hormone therapies fill the treatment gap between lifestyle therapy and bariatric surgery. As we have already mentioned, lifestyle therapy causes weight loss about 5% or 5 to 8%. But it has not shown to affect the adverse cardiovascular events associated with obesity. Lifestyle alone will not reduce significantly. On the other hand, bariatric surgery can reduce the weight loss, and also it causes a remission of type 2 diabetes, and also it reduces cardiovascular events. So lifestyle therapy is insufficient. Bariatric surgery, highly effective, but it is very invasive. It is not desired by some patients. That's where the pharmacotherapy strikes, the balance between these two, effectiveness and invasiveness. There are three reasons for it. The NSH therapies help to address the disease mechanisms of obesity by targeting the hormonal pathways that control appetite, hunger, satiety, satiation, and cravings. Second, NSH therapies are titratable. They allow dosing to minimize side effects and maximize weight loss, making them well suited to individualized care and address the obesity epidemic. The prior guidelines suggested trial lifestyle intervention prior to pharmacotherapy. It is a setting the stage for failure because we do know lifestyle intervention alone, even though it can cause weight loss, it has not shown to improve the adverse cardiovascular events that could be associated with obesity. So patients should not be required to try and fail lifestyle changes prior to initiating pharmacotherapy. Lifestyle intervention should always be offered in conjunction with nurse therapy. So lifestyle intervention needs to be done. It's very healthy, less side effects, very important, but it's not alone adequate. Lifestyle, as you can see, it can reduce weight loss by 5%. It improves the triglycerides, blood pressure, fasting glucose, reduce the risk of type 2 diabetes. The pharmacotherapy can reduce the weight loss 10 to 15%, sometimes even 20%. It improves metabolic dysfunction associated steatotic liver disease, improvement of type 2 diabetes, that means decrease in hemoglobin A1C, improvement in obstructive sleep apnea, reduced risk of cardiovascular disease. It also has been shown to reduce the cardiovascular mortality and heart failure events. Bariatric surgery or metabolic surgery reduce the weight, causes weight loss, and also reduce the risk of mortality. Let's move on to the pharmacotherapy. The pharmacotherapy is available for obesity since early 20th century. The initial medications used were thyroid hormones, dinitriphenol, and amphetamines. Those are all weight loss producing agents, but it had significant side effects. So it's no longer used. Then second generation agents like fenfluramine, dexfenfluramine, sibutramine, and lorcaserin came into effect. Again, they had same side effects. Then orlistat, phentermine topiramate, naltrexone, bupropion, still being used, but it is not as effective as the newer agents, which we are going to discuss. Third generation weight loss medications. The medications we use are liraglutide, GLP-1 agonist, semaglutide, GLP-1 agonist, tirzepatide is a dual-action GLP-1 and GAP agonist. These medications are initially approved for type 2 diabetes. Now they are approved for obesity. The side effects for all these medications are very similar: nausea, diarrhea, vomiting, abdominal pain, constipations. But these side effects can be mitigated with dose reductions or behavioral modifications, such as hydration. Liraglutide causes weight loss of 8%, semaglutide 15%, and tirzepatide 20% at their maximal dosages. One should know the contraindication of these medications, GLP-1 and GAP agonists. When there is history of medullary thyroid carcinoma, which is rare, and MEN syndrome, multiple endocrine neoplasia syndrome type 2, or when the patient is hypersensitivity to these medications. Liraglutide needs to be given daily dosing. Semaglutide and tirzepatide is weekly dosing. GLP-1 agonists are safe and effective. One has to remember, obesity is a chronic disease, so they need medications for long term and they need to be effective. Among these three, liraglutide and semaglutide are GLP-1 agonists. GLP-1 regulates blood glucose by stimulating glucose-dependent insulin secretion, slows the gastric emptying, and increases satiety, and collectively promoting weight loss. Tirzepatide, it's a dual-acting. It acts on GLP-1 and GAP. GAP is a potent, gut-derived, nutrient-stimulated hormone that stimulates glucose-dependent insulin secretion in response to food, contributing to endogenous postprandial insulin release. Semaglutide and tirzepatide, they have the highest efficacy and are the obesity medications of choice. The clinical trial and real-world observational data supports slightly greater weight loss with tirzepatide. So in this diagram, as you can see, the lifestyle modifications using diet and exercise can go up to an 8% weight loss. Sorry. The medication like orlistat, naltrexone, bupropion, liraglutide, phentermine, topiramate can result in up to 10% weight loss, liraglutide 8%. When you use GLP-1 agonist, the weekly ones, semaglutide and tirzepatide, can reach up to 20% weight loss. But surgery is the most ultimate because it can cause weight loss up to 25%. Liraglutide. The indications are the BMI more than 30 or more than 27 with weight-related comorbidities. Start the dose with 0.6. Increase weekly up to 3 milligram. They can be stored for 30 days at a controlled room temperature or longer with refrigeration. As we already discussed, it can cause 8% weight loss. Semaglutide available as Ozempic and Wegovy. This is GLP-1 agonist. Indication for obesity and weight-related comorbidity. Start with the 0.25 every 4 weeks, need to be increased to 1.7 or 2.4. Ozempic can be stored for 56 days, Wegovy for 28 days in controlled room temperature, longer with refrigeration. It can cause weight loss up to 15% with semaglutide. The contraindications are medullary thyroid carcinoma and family history of MEN type 2, and also hypersensitivity to the medications. Be cautious in using in patients with acute pancreatitis, acute gallbladder disease, hypoglycemia, renal impairment, acute kidney injury, hypersensitivity reaction, suicidal behavior, and ideation. The side effects of all these three drugs are very similar: nausea, diarrhea, constipation, vomiting, and injection site reactions. Tirzepatide, indicated for obesity and overweight with weight-related comorbidity. In start with 2.5, escalate the dose every 4 weeks to 5, 10, and 15. It can be stored for 21 days at controlled room temperature, longer with refrigeration. It can induce weight loss up to 20%. There are multiple trials done with these medications in patients with type 2 diabetes and cardiovascular risk. The one done with liraglutide, 1.8 milligram. The study was done over 3.8 years. It has decreased the cardiovascular death, acute myocardial infarction, and cardiovascular accidents. But it didn't have any effect on the heart failure. Semaglutide 1 milligram, again, it reduces the primary outcome, cardiovascular death, myocardial infarction, cardiovascular accidents, but there is no effect on the heart failure. Tirzepatide has been undergoing evaluations. We do not have the results yet. The SELECT trial using different doses. Semaglutide 2.4 milligram. Again, the primary outcome, decrease of cardiovascular death and cardiovascular mortality, no difference in the heart failure. In SUMMIT trial, on the other hand, you can see it's done over 2.3 years, not only reduces cardiovascular death and worsening heart failure, it also reduces heart failure. That's where the tirzepatide, which is GLP-1 and GAP agonist, dual agonist. And there is another study is being done at this point. It is estimated to be completed in 2027. The NOSH therapies, especially in patients with type 2 diabetes, reduce the weight, reduce the cardiovascular death, and reduce myocardial infarction and reduce stroke. In cardiology, most of the obesity patients do have one of these complications or associated disorders, like atherosclerotic cardiovascular disease, atrial fibrillation, heart failure, hypertension, hypertriglyceridemia, and dyslipidemia. So when there is a weight loss, you should be able to de-escalate antihypertensive, de-escalate diuretics to avoid intravascular depletion, because these NUSH therapies can cause dehydration per se. In patients with straightforward type 2 diabetes, consider repeating thyroid hormone levels and adjust the dose of levothyroxine, because weight loss will be profound. And also reduce the medications to avoid hypoglycemia. Hypoglycemia is one of the side effects of NUSH therapies. Currently, there is no screening for thyroid needed before starting NUSH therapy, even though medullary thyroid carcinoma and men type 2 are contraindications to use NUSH therapies. In nephrology, when the patient has chronic kidney disease, AKI, acute kidney injury, can happen in the setting of GI side effects. Adjust the hemodialysis protocol, adjust dry weight in hemodialysis in patients undergoing active obesity treatment. When they have underlying metabolic dysfunction associated steatotic liver disease, GERD, or gallbladder disorders, so one should look for gallbladder disorders, low threshold to consider ursodiol in patients with cholelithiasis. Adjust anti-reflux medications. In OBGYN, PCOS, and infertility, tersapeptide may reduce the efficacy of some contraceptive medications. Weekly NASH therapy should be discontinued more than 2 months prior to conception. When they have underlying psychiatric disorders like eating disorders, depression, anxiety, and severe mental illness, consider re-evaluating medication dosages after significant weight loss, as the therapeutic window of some psychotropic medications may depend on body weight. Hem-onc, for some cancers and venous thromboembolism, consider re-evaluating the medication dosages because of significant weight loss, as chemotherapy and anticoagulant dosing may be weight-based. In surgery, the GLP-1 agonist may be preoperatively continued in patients without elevated risk of delayed gastric emptying and aspiration. The decision to hold semaglutide and tirzepatide when there is lack of evidence to inform the duration, but 1 week may be considered. In OSA patients, adjust the CPAP settings. Repeat OSA assessment is needed because of significant weight loss. Geriatrics, very important. Excessive weight loss and high risk of sarcopenia, the frailty in this age group. Re-evaluate medications and dosages after significant weight loss to reduce the risk of polypharmacy. Obesity treatment is multidisciplinary. Clinicians should incorporate shared decision-making into their treatment approach to best balance risk and benefits. Off-label, but evidence-based strategies may be considered to mitigate potential harms and optimize health outcomes, like lowest therapeutic dose for weight loss maintenance and combination therapies. The patient experience is very important when you are treating obesity, because it is chronic conditions. Most of them need lifelong treatment. Person's first language should be used. The clinician should make every effort to validate the lifelong journey that patients experience with this chronic disease. Identify contraindication to obesity medications and obtain anthropometric, and clinical data to aid in the diagnosis and staging of obesity. The frequency of follow-up depends on the stage of the patient's journey and the practice capabilities. More frequent interaction with the weight management team have been associated with the great weight loss and weight loss maintenance success. It's very important in any chronic disease. Frequent monitoring is the important tool. The monitor for rapid weight loss, signs or symptoms of vitamin and mineral deficiencies, signs or symptoms of disordered eating behaviors or excessive weight loss associated with frailty. The goals of obesity treatment should be tailored to the individual. The reasonable initial goal is to achieve the weight loss of more than 5%, which is associated with improvement in triglycerides, fasting blood glucose, and systolic blood pressure, as well as prevention of incidence disease. Individuals who seek to resolve weight-related comorbidities such as cardiovascular disease, sleep apnea, metabolic dysfunction associated steatotic liver disease, they should aim for more than 10% weight loss. Patients' quality of life, functional status, and psychosocial health should also be considered as part of one's treatment goals, supporting holistic approach to obesity care. Therapies for weight-related comorbidities and weight-based medication should be de-escalated as needed. As a patient achieves their weight management goals, actively reduce or discontinue interventions to avoid harm from overtreatment, mitigate polypharmacy, and reinforce progress. Long-term treatment should be the default plan. Obesity medication should not be discontinued unless determined by the patient and our treating clinician, but this commonly results in weight regain. So very important. Obesity is a long-term disease. The treatment has to be lifelong. When you make the diagnosis, prescribe lifestyle modification and NASH therapy. Months 1 to 6, assess the treatment goals, whether the weight loss is achieved. Consider monthly assessments. Consider alternative to NASH therapy if the medications didn't improve or has a significant side effects. Month 6 to 7, monitor change in weight from baseline, evaluate status of other treatment goals. Again, consider if the goals are not met. Continue lifestyle changes that are beneficial for weight loss. And 7 months later, monitor change in weight from baseline, evaluate status of other treatment goals, schedule annual appointments at a minimum to guide the weight management plan. Continued standard healthcare maintenance. Weight management is best optimized using team-based approach to create personalized health assessment and identify contributing factors, modifiable risk factors, and comorbid conditions. Early involvement with behavioral therapists can be beneficial to recognize individual stressors, encourage social support systems, identify long-term patient goals, and set reasonable expectations. Health coaching with registered dietitians and the exercise physiologists has been shown to improve weight loss, physical activity, and metabolic markers. Team of clinician pharmacy support is important in monitoring medication, side effects, therapeutic goals, and improving access to care. So this is very important. It is the multidisciplinary work. Doctors and nurses, nurse practitioners, so basically the providers, assess the patient, prescribe the medications. Pharmacy help us to reduce the dose or adjust the dose based on the side effect profile. And behavioral therapists, exercise physiologists, and registered dietitians help us with the diet and psychology and other areas. Finally, metabolic surgery. The current recommendation based on the Diabetes Care 2025 consider metabolic surgery as weight and glycemic management approach for people with the BMI more than 30 or more than 27.5 in Asian American individuals. It is recommended to be performed in high volume centers because the people who have more experience have less post-operative side effects and better efficacy. They should be evaluated for comorbid psychological conditions and social and situational circumstances. They should receive long-term medical and behavioral support and routine micronutrient, nutritional, and metabolic status monitoring. And most of the time in the United States, these two procedures are performed in patients with obesity: vertical sleeve gastrectomy, Roux-en-Y gastric bypass. These surgeries have a huge beneficial effect on the patients. One, weight loss is 29.1 RYGB, 22.8% with VSG. Diabetes remission is very significant, 86.1% with RYGB, 83.5% with VSG. The Stampede trial is going to check the surgery and medication potentially eradicate the diabetes efficiently. We are waiting to get that results back. So in all the patients who undergone metabolic surgery / bariatric surgery need to be monitored for vitamin and mineral deficiencies, anemia, osteoporosis, dumping syndrome, severe hypoglycemia. Dumping syndrome usually occurs 10 to 30 minutes after the meal and may present with diarrhea, nausea, vomiting, palpitations, and fatigue. The severe hypoglycemia usually happens 1 to 3 hours after the meal. That needs to be monitored. This concludes the talk on obesity based on JACC guidelines and Diabetes Care 2025.